As part of this guide series, I've been going over 6 questions that you can ask your patients at any time during your rotation. And if a patient is post-surgical, then it's basically the same as surgery questions. Are you in pain? Are you eating? Do you have any nausea or vomiting? Are you peeing and pooping? And have you started walking yet? But if somebody's coming in preparation for delivering a baby, there are a specific set of questions that you're going to ask if they're coming in for labor, okay? And that's going to be, are you having contractions? And if so, are they getting stronger or more frequent? Did you experience leakage of fluid? Are you having any vaginal bleeding? And is the baby moving? So this is the set of 4 questions that I want you to ask any patient that comes in labor. The next 2 questions are questions that are immediately going to help you build rapport, which is especially useful if you are a male student, because some people can be justifiably a little bit nervous when there's a male medical student, okay? So the questions I always liked asking is, number 1, do you know what you're having? As in, do you know if you're having a boy or if you're having a girl? And have you picked a name yet? And these 2 questions I found were ways to instantly build rapport with patients because, you know, their entire world is focused around having their baby right now. And if you ask questions like that, they're going to want to love to tell you about the major thing that's going on their life right now. So these are great questions to kind of get the conversation started and help them loosen up a little bit around you. So OBGYN is kind of divided up between several different situations. First of all, you have clinic, where people are going to be coming in for their prenatal evaluations and visits. Triage is when a patient is coming in and they're worried that they may potentially be in labor. And then if they get admitted, they'll go to the labor and delivery unit where you will be watching them until they deliver. And then you have GYN, which is going to be a lot of surgeries like hysterectomies and oophorectomies and all things like that. So when patients are coming into triage, you want to assess if they are having true labor versus false labor. And I'm just going to give you a little bit of a spoiler right now. But if you think it's false labor, there's a thing called Braxton-Hicks contractions. They're real contractions, but it's not heralding the onset of labor. And then finally, it's important to establish rapport early, especially if male, like I mentioned before. So definitely make sure to use these 2 questions here. So you need to know how to say the patient's gravidity and parity. So what are these? The gravidity is the total number of times that a patient is pregnant, and the parity is the number of viable deliveries that they had. So when you are talking about a patient, you'll say this is a G4P2, which means they've been pregnant 4 times, they've had 2 viable deliveries. So when we're talking about a patient, there's also this more extended form called the GTPAL, which is an acronym. So G is for gravidity, T is for term births, P is for preterm births, A is for abortions, and L is for living children. Okay, so in this example, G4P2012 means that they had 4 total pregnancies. They have 2 of those pregnancies which were term births, 0 were preterm, and 1 was an abortion, and they have 2 living children. So that's how you use the GTPAL acronym. All right, next, there are 2 important weeks that you absolutely have to remember in OBGYN, okay? And that's going to be week 34 and week 37. And why is it important to know these 2 weeks? So first of all, at week 37, that's going to be where you're going to be determining if you're term or preterm. That's the cutoff right there. So that's why week 37 is so important. And then if you're week 34, this is a very important time because if you are going into labor before week 34, your goal is to keep them pregnant, okay? You want to do expectant management, you want to give steroids, and you want to give antibiotics. If they are after week 34, and in between week 37 or further, then you actually just want to go straight to delivery. Even though the baby is still preterm in terms of being between 34 and 37 weeks, they are mature enough at that stage where the benefits of just delivering right away if somebody's in labor outweighs trying to keep them pregnant longer until week 37. So this is why you need to know week 34 and week 37. The next thing I want to mention is that we have this concept called preterm premature rupture of membranes, and then you have premature rupture of membranes over here. So basically, this is when a patient's water breaks. And so if it's before week 37, we call it preterm premature rupture of membranes. This is important because it has a lot of different complications that can occur. And then if they just have rupture of membranes before they go into labor, but they're after week 37, then it's just called premature rupture of membranes. Next is how do we say which week a patient is? So you just say the week and day. So for example, this is a 24-year-old G2P1 who's at 36 and 5. So that would be week 36, day 5. And that's how you would say that. Now let's look at the pregnancy timeline overall. So we have first trimester, second trimester, and third trimester. And let's start with some topics during the first trimester. So one thing that we want to do is early on, we want to use ultrasound to check the gestational age of the baby. Because a lot of times we use the last menstrual period to figure out when the expected delivery date is going to be. But the most accurate way is actually to use an ultrasound and take a look at how large the fetus is. So the earliest finding that you're actually going to be looking for is going to be a gestational sac, which you're going to see at around 4.5 to 5 weeks of pregnancy. The next thing that you look at, and is the length that you're going to measure, is going to be the crown rump length. So this is something important to remember, because your residents or attendings are going to ask you, what are they looking at when they're trying to figure out how old this baby is? And what is a rule that you can use to estimate the delivery date based on the last menstrual period? That's going to be called Nagel's rule, which is the last menstrual period plus 7 days minus 3 months. And that's going to be your estimation based off their last menstrual period. So other things that you want to do for the first trimester prenatal visits are going to be getting an RHD type-in red blood cell antibody screen. You want to be checking, urine protein, asymptomatic bacteriuria, a lot of STI testing, and things like that. So one thing that I want to ask is, what RH status of the mom and baby is worrisome for alloimmunization? Because you need to realize that there's only certain situations where we're going to be worried that the mom is going to develop antibodies against future babies. So that's going to be an RH negative mom and an RH positive baby. So when is RhoGAM given if there is an RH negative mom and an RH positive baby? That's going to be at 20 weeks and then again at delivery. What is a test that we can use to determine the amount of RhoGAM to give? That's going to be called the Kleihauer-Betke test. And I just added this here because I remember this is a UWorld question, so you may be tested on this on your board exams. And then finally, should asymptomatic bacteriuria be treated in pregnant patients? And the answer is yes, because patients with bacteriuria who are pregnant have been shown to have worse outcomes if it's not treated. This is different from asymptomatic bacteriuria in a typical adult population who are not pregnant, in which case there is no indication for treating. Now let's move on to the second trimester. So at this point, we're going to be using ultrasound to check for intrauterine growth restriction and neural tube defects, okay? So what lengths are we going to be measuring now? We're no longer looking at the crown rump length, but we're going to be looking at several things that your residents may ask you about, and that's going to be the biparietal diameter, the head circumference, the femur length, and the abdominal circumference. What are two types of intrauterine growth restriction? That's going to be symmetric and asymmetric intrauterine growth restriction. And so the difference between that is that when a baby is coming in and you do an ultrasound and all parameters, including the head circumference, are small, this is what we call symmetric intrauterine growth restriction. And this is usually due to early insults like neural tube defects, aneuploidy, and early transplacental infection. So if you have everything small, for example, the femur length is small, the abdominal circumference is small, but the head circumference is preserved, this is called asymmetric intrauterine growth restriction. And this is usually due to decreased nutrients from a maternal vascular disorder, for example, hypertension, smoking, drug use, diabetes, things like that. And the baby is actually able to preserve blood flow to continue the growth of the brain, even though other parts of their body are, not getting as much nutrition. Again, asymmetric growth restriction usually occurs a little bit later than symmetric growth restriction. In terms of aneuploidy screening, if you see increased AFP, this generally will suggest a structural defect, for example, a neural tube defect, omphalocele, something like that. And the way I like to think about it is that there's a structural defect in the baby and they're kind of just like leaking AFP, and then we can detect that when we get our second trimester screen. If you see decreased AFP, this is often due to a chromosomal defect like Down syndrome. So one of the things you're going to see is that we have this second trimester screen. You can either do a triple screen or a quadruple screen. And so Down syndrome and Edwards syndrome, you can see that they have decreased AFP, which is one of the ways that we can screen for some of these chromosomal defects. Finally, what are some aneuploidy screening tests in general? So we have the nuchal translucency, which is something that we check for when we do the ultrasound, and that can be a sign of a neural tube defect, often in the first trimester. Then in the second trimester, we often do the triple or quad screen. And then as a confirmatory test, we do this really nice, very specific test called the cell-free fetal DNA. Finally, after a screening test comes back positive, you then want to do a diagnostic test to really nail the diagnosis. And that's going to be invasive measures, for example, with chorionic villus sampling, which is usually around 10 to 14 weeks, so a little bit earlier on, or amniocentesis, which is going to be 15 weeks or later. So one thing that we also check for is short cervical length, which can be screened between 16 and 24 weeks. And so what is this associated with? So if a patient has a short cervical length, this is associated with the risk of preterm labor. So if they have a cervical length less than 2 centimeters or less than 2.5 centimeters with a history of preterm labor, this is going to be a known risk factor for a preterm labor. What is a lab test that you can use to assess the short-term risk of preterm labor? That's going to be a fetal fibronectin at 24 weeks and 33 and 6 weeks. So a fetal fibronectin, the way I was taught it, is kind of the glue that holds the membranes together. And so when you start to detect this, then that's a sign that it's kind of leaked out a little bit, and that can indicate a risk of premature labor. And finally, when to screen for gestational diabetes, that's going to be at 24 to 28 weeks. And gestational diabetes increases the risk for fetal macrosomia. And what complication of pregnancy? That's going to be shoulder dystocia, because a lot of these babies are going to be larger than normal, and so they're going to have trouble coming out of the birth canal. Now let's move on to the third trimester. So what is a technique that we can use for determining the position of a fetus inside the uterus? That's going to be Leopold's maneuver. So this is a graphical depiction of how you perform Leopold's maneuver. What is the ideal baby positioning during a vaginal birth? This is called occiput anterior, and this is very important to know, and you're going to be asked about this. And so this is going to be when the baby's head is going down first, and then posteriorly, the kind of back of their head is facing like this, so they're facing down towards the ground. What is a baby positioning that is not as good? It's associated with developmental hip dysplasia and risk of cord prolapse. So this is when the baby is actually feet first, and you can see how the umbilical cord can kind of get tangled up in here and can prolapse out of the vagina. And then finally, what is a method that you can use to manually try to flip this baby to occiput anterior? So we're going to try and flip this guy around so his head is the presenting factor first. And that's going to be called external cephalic version. And you're basically just using manual techniques to try and flip the baby to the correct position. Next, let's talk about how much the baby should be moving after week 28. This is going to be greater than 10 times in a 2-hour period. This is important to know because you want to counsel your patients about this. And if the baby suddenly is moving less than that, that can be a little concerning. When should you screen for group B strep? Obviously, group B strep is a very important thing for us to check for because it can lead to meningitis if it is not treated. And so this is going to be at 36 to 38 weeks gestation. Mild irregular uterine contractions, which produce no cervical change. I alluded to this earlier in the presentation, but these are called Braxton-Hicks contractions. And then so this is not an indication of true labor. This is going to be false labor. And then what is the definition of a normal reactive non-stress test? So a non-stress test is when we're monitoring, basically it's the fetal heart rate monitoring. And so you should see 2 fetal heart rate accelerations within 20 minutes. And that's going to be a normal reactive non-stress test of a baby. So if the non-stress test is non-reactive, then we go and get this more in-depth test called the biophysical profile. What is the term for thinning of the cervix during labor? That's going to be called effacement. What are tests which can indicate ruptured membranes by looking for the presence of amniotic fluid? That's going to be Ferning or a nitrazine pH test, and blue is going to be positive. So Ferning is when you kind of take a little bit of that fluid and you just put it on a slide and you see if you see this Ferning pattern, and then you test the pH because the pH is going to be higher if there's ruptured membranes. And so a blue test is going to be positive and indicate possible ruptured membranes. Stages of labor, there's going to be 3 stages of labor. So stage 1 is 0 centimeters of cervix dilation to 10 centimeters. Stage 2 is 10 centimeters to baby delivery. And stage 3 is finally the delivery of the placenta. What is a mnemonic? And this is very, very high yield, very important to know. What is a mnemonic for different causes of fetal heart rate accelerations and decelerations? That's going to be veal, CHOP, okay? You really need to know this mnemonic. So veal CHOP, you can have variable decelerations, early decelerations, accelerations, and late decelerations. So a variable deceleration is going to be due to gourd compression. Early deceleration is from head compression. A regular acceleration is just normal, and a late deceleration is placental insufficiency. So let me show you what these kind of look like. So this is an early deceleration. You can see that when the contraction comes down here, the early deceleration kind of happens right before it or kind of coinciding with it. And so that's actually the head of the baby is getting compressed. And this is actually relatively okay. What you really want to start worrying about is when they start having late decelerations. So you can see that the contraction comes here and then the fetal heart rate deceleration comes after. This is a lot more concerning because this is going to be the placental insufficiency, which means there's like lack of blood flow and lack of oxygen. Okay, and then you also have this thing called variable deceleration. So the thing that differentiates variable decelerations is they can kind of occur randomly throughout, and it's going to be a much more kind of deeper nadir and more of a V-shaped kind of deceleration. And this is going to be cord compression. So this is also concerning because if you have cord compression, you're also potentially going to have compromise of oxygen and blood flow to the baby. So again, remember veal CHOP. And then categories of fetal heart rate tracings to assess the acid-base status of the baby. This is also extremely, extremely high yield. You need to know the categories of fetal heart rate tracings because there's category 1, which is good, and it goes all the way to category 3, which is really bad, and you basically need to do a C-section and deliver the baby right away. So in terms of category 1, you want to see a baseline heart rate of 110 to 160. You want to see moderate variability in the heart rate. So for example, it should kind of be going up and down and whatever like that. It's actually really bad if there's like no variation in the heart rate. And then it's okay to have accelerations and early decelerations. Category 2, you're going to start having late decelerations or variable decelerations or other concerning signs. So this is indicating that the baby may not be doing as well. And then finally, with category 3, you're going to have absent variability, recurrent late decelerations, recurrent variable decelerations, bradycardia, sinusoidal pattern is another thing you may see. And that's going to be category 3, which means you need to deliver the baby right away. What is the range of a normal fetal heart rate? That's going to be 110 to 160 beats per minute. All right, and then let's go on to some more questions. What is the amount of blood loss to be considered postpartum hemorrhage? That's going to be greater than 500 cc's of blood loss if it's vaginal delivery, or greater than 1 liter of blood loss with a C-section. What is the most common cause of postpartum hemorrhage? That's going to be uterine atony, and this is a very high yield question to know. And then what is the most common cause of postpartum hemorrhage with a firm uterus? That's going to be a genital tract laceration. So with uterine atony, you're going to feel a very they're going to deliver the baby and you're going to feel a very boggy uterus. Basically, they haven't clamped down the blood vessels in their uterus yet, so it's just continuing to hemorrhage. So what you need to do is you need to do a massage and also potentially give medications. So treatment for uterine atony is uterine massage and then Pitocin, Methergine, or Hemabate. These are all things that are going to help vasoconstrict. So contraindication for Methergine, that's going to be hypertension. Contraindication for Hemabate is going to be asthma. These are two important things side effects that you need to know. And then preeclampsia is defined by gestational hypertension plus what other finding? That's going to be proteinuria or signs of end organ damage, another important thing that you need to know. And then what is a complication associated with mono-di twin pregnancies and a complication associated with mono-mono twin pregnancies? So first of all, let's do a quick review of mono-di twin pregnancies and mono-mono twin pregnancies. So this is going back to first aid, but twinning, you can have fraternal twins, which are dizygotic, and identical twins, which are monozygotic. And based on when the basically the embryoblast splits, that's going to tell you if you're going to be dichorionic and diamnionic, or you're going to have a shared chorion or a shared amnion. So for example, if you split between 0 and 4 days, you are a di-di twin, okay? So they're basically two separate, completely separate compartments. If you split between 4 and 8 days, then you get this mono-di pattern. And if you split between 8 and 12 days, you get mono-mono twins. So in the mono-di twins, you can see that they share the same placenta. And so one of the things that happens is one of the babies will actually take more of the nutrients, and the other baby is going to get less of the nutrients, and that's going to be called twin-to-twin transfusion syndrome. So that is one of the major complications of a mono-di pregnancy. And then a mono-mono pregnancy, they have an entirely shared space in this place. And so the major complication here is going to be umbilical cord entanglement, because you can see both of these umbilical cords can easily get tied around, twisted around each other. They can maybe even like surround the neck of one, or just cut off the blood supply to one of the twins. And that's a very, very dangerous complication. Okay. So complication with mono-di twin pregnancy is going to be twin-to-twin transfusion syndrome. And then with mono-mono twin pregnancy, that's going to be umbilical cord entanglement. What is the duration of no cervical change, which is considered an arrest of labor? So this patient is laboring, it's hour 2, hour 3, hour 4, nothing is happening, their cervix is not getting more dilated. At what point is this going to be arrest of labor? And then you need to do the next steps, okay? So if they have adequate contractions, you give them 4 hours to have cervical change. And if they're not having significant cervical change, you consider that arrest of labor. And then if they have inadequate contractions, then you give them up to 6 hours. And so what is the treatment for arrest of labor? That's going to be immediate C-section. Artery inside the round ligament, I'm going to put this as high yield, high yield, high yield, because even though this is like not very like relevant or useful at all, you are definitely going to be pimped on this, in my opinion, on your GYN rotation, because they always like to pimp about this. But the artery inside the round ligament is called the artery of Samson. Okay, so you have all these arteries going to the uterus, and then in this, they're just going to point to this one round ligament here, and they're going to be like, what artery is in there? And that's going to be Samson's artery. So make sure you know that. Next, I want to talk a little bit about perineal tears, because these are genital tract lacerations that are very frequent during delivery. So a first degree tear is just a little bit of skin tearing. A second degree tear is going to be some of the muscles being torn. And then the third degree tear is going to go all the way down to the anal sphincter. So this can lead to a lot of fecal incontinence down the line. And then fourth degree tear is even worse, with the rectum being torn. So these are very important things to know. And a lot of times after delivery, you're going to see your residents have to go in and suture up and try and repair these genital tract lacerations and perineal tears. All right, next I want to talk about a few conditions that are kind of high yield. So we've got placenta previa, we've got vasa previa, we have placenta accreta, and then we have placental abruption, we have uterine rupture, and then we have breech presentation with umbilical cord prolapse. So let's take a look at each of these one by one. Okay, so first of all, placenta previa. This is when, normally your placenta is up over here, it's kind of out of the way, it's providing nutrients to the fetus, but in placenta previa, you have this problem where the placenta migrates and is basically right over the cervix, which is going to make delivery very dangerous and very difficult, because you're delivering through the placenta, it's going to be bleeding like crazy. So what is the most important risk factor for placenta previa? That's going to be a history of a C-section. So C-section is going to cause some abnormal scarring, and that's going to lead to an increased risk of this placenta actually going over the cervix. So why is multiple gestation a risk factor for placenta previa? So twins have an increased risk of placenta previa. That's because a larger surface area is needed for the placenta. So for example, if the placenta was here, but you have twins, it may be a little bit longer. So then you get basically placenta previa because of the bigger placenta. How does placenta previa usually present? That's going to be painless vaginal bleeding. And then what is the management of placenta previa in the second trimester? So that's going to be kind of relatively early. So that's actually going to be expectant. So you're not going to do anything about it if it's relatively early on in the pregnancy. And what is the reason that it can be managed expectantly in the second trimester? This is because there is transmigration of the placenta. So a lot of times if you have placenta previa, it may eventually migrate as the baby gets larger and then kind of get out of the way, so it's not overlying the cervix anymore. And then what is the management of placenta previa in the third trimester? That's going to be a C-section at 36 and 0 or 36 and 0 to 37 and 6 weeks. And you can give a short course of antenatal steroids. Next, let's talk about vasa previa. So this is different from placenta previa because your placenta is over here now, but you've got all these like blood vessels that are overlying the cervix in this case. And this is very dangerous. So in UWorld, you're going to get a question stem that's going to be a patient with rupture of membranes. Then they have painless vaginal bleeding. And then suddenly the fetus is becoming very bradycardic. Okay, this is different from placenta previa, where it's really just going to be painless vaginal bleeding, and then you'll find that they have placenta previa. But now the baby's getting sick, okay? This is because their blood flow is getting compromised. And so this is going to be a question stem that's leading you towards vasa previa. The frequency of variable decelerations with vasa previa is often higher. Remember, variable decelerations correspond to cord compression, and these babies are having cord compression and compromised blood supply. The treatment is betamethasone at 28 to 32 weeks with a weekly non-stress test at 32 weeks and hospitalization at 30 to 34 weeks. This is showing you how high risk it is because, even early on, you're going to get these patients hospitalized to monitor them more closely. The treatment is a C-section, and the goal is to deliver the fetus before rupture of membranes or onset of labor. Next, let's talk about placenta accreta. So this is basically when the placenta implants into the muscle wall. So placenta accreta is kind of the basic one that you get. And then increta, it's getting a little bit further in. And then percreta, it's actually going to the bladder or other nearby organs. So this is just to let you know the different terminology. What is the most important risk factor for placenta accreta? That's going to be a history of a C-section again. Again, with abnormal anatomy, there's more chance for these abnormalities to happen. And then next, let's talk about placental abruption. So this is, the placenta's here, and all of a sudden you got this big bleeding blood clot area behind in this area. So how does placental abruption present? This is going to be painless vaginal bleeding plus possible back and abdominal pain. One question is, are patients with late-term pregnancies greater than 41 weeks at greater risk for placental abruption? And the answer to that is going to be no. What are risk factors for placental abruption? That's going to be your classic hypertension, smoking, cocaine, trauma, and history of placental abruption. Okay, and what is a feared complication of placental abruption? That's going to be DIC, so make sure you know that. And is ultrasound sufficient for diagnosing placental abruption? That's going to be no. So sometimes you are not going to be able to see this collection of blood back here with an ultrasound because the texture of the echogenicity of blood is actually very similar to the echogenicity of the placenta. So you may not have a very accurate test if you just use ultrasound alone. Next, let's talk about uterine rupture. And I love this picture because it's so memorable from UWorld with this like baby's hand reaching out of the uterus here. And so this is going to be a very classic question stem that you're going to get on your UWorld or step 3, step 2. So the baby is getting delivered when suddenly the head recedes back into the vagina and they begin to develop a non-reassuring fetal heart tracing and mom starts to get severe abdominal pain. This is going to be called uterine rupture. And so the pathognomonic finding for this is what they're kind of describing here, and that's called loss of fetal station. So fetal station is, if this is the birth canal, you have kind of -3, -2, -1, 0, 1, 2, 3, and say the baby's head is initially out here, and then all of a sudden it goes from +3 fetal station to -2. That's recession of the baby head, and that's going to be concerning for uterine rupture. Speaking of memorable UWorld pictures, this is another one that you're classically going to see, but this is for uterine inversion. And the treatment for this is basically you punch the uterus back into place, basically. So this is another very memorable UWorld picture. All right, a few last questions. All right, so what is the first line maneuver for shoulder dystocia? So the baby is coming out, all of a sudden it gets stuck. What are we going to do right away? This is going to be Mick-Roberts maneuver and suprapubic pressure. So management of shoulder dystocia, we're going to elevate the legs into the Mick-Roberts position. So basically the patient is going to be delivering and then the baby gets stuck and you're going to push their legs into hyperflexion. So like as far back as possible. You're going to apply suprapubic pressure. So you're going to press down kind of on their bladder, their uterus area to try and push the baby out. And then other options are episiotomy to try and enlarge the vaginal opening. And then there's some other things called like the Wood's corkscrew maneuver and the Gaskin maneuver, which you can also consider. But the first line maneuver is going to be McRoberts maneuver. Score for assessing how well a baby is doing after birth, that's going to be the Apgar score. And then are Apgar scores predictive of long-term mortality or neurological outcome? This is a very high yield question. This is going to be no, because a lot of people are going to be like, oh my gosh, the baby had an Apgar score of 6 when it came out. Like this means he's going to have some kind of mental disability later, or they're going to have some neurologic deficit later. But there is no correlation for Apgar scores and long-term outcomes. The main reason we use Apgar scores is to just tell us how sick a baby is right after delivery. Okay, and I just want to touch upon, the Apgar score being developed by Virginia Apgar, really one of the titans of her time. And the Apgar score is an acronym that describes appearance, pulse, grimace, activity, and respiration of the baby. So 7 to 10 is normal, 4 to 6 is moderately depressed, and 0 to 3 needs immediate resuscitation. All right, that's it for my third year medical student guide to your OBGYN rotation. I hope that was useful for you guys. I told you that it would be high yield, and I really hope I was able to deliver on that. If you found the content useful, please leave a comment down below. Please like the video and subscribe. It really helps the channel out and will help you be notified when I release more videos in the future. And I really appreciate you watching. I hope you get honors on your rotation, and take care.